alaikum, my respected teachers and the very learned delegates from home and abroad. There is a context of endocrine hypertension. The context is there is about 30% of the population under the age of 40 are hypertensive. And the importance of endocrine-mediated hypertension is that nowadays, among all this secondary hypertension, the endocrine hypertension occupies almost half of the cases. And more importantly, the most cases, the cause is clear, and once the diagnosis is made, there is specific therapy. So you all know the causes for endocrine hypertension. All the endocrine organs are virtually involved, but we always give our stress on adrenal gland. We know all the syndrome, Cone, Cushing, and the pheochromocytoma, and rarely there are some congenital adrenal hyperplasia. So it is important for us to know who are the people who need screening. You know about the early onset resistance and the severe hypertension, but you have to keep in your mind also that when there is sudden increase in BP, there is organ damage, and as today has been discussed, the nocturnal dip during ambulatory BP is another indication. And if you look down to the path to find out the endocrine causes, you have to look for the clue where you can find out Cushing syndrome, the pheochromocytoma, the thyroid, and other things. So again, you have a second diagnostic look after you have started treating the patient. Excessive drop of potassium in a small dose of diuretic, excessive drop of GFR, a remarkable resistance hypertension, and the labile hypertension will again call you to take an action for screening for secondary hypertension. So I start with my case, date back to 2007, when we had limited resources. To be honest, as of now, after 17 years, I myself remain in the same place. So I decided to open this case because I myself is also not very aware of this condition. And I'm very fortunate that Charmaine is here. She's much more knowledgeable on that. She's doing her PhD on Cone syndrome, and probably she will contribute the point that I cannot really clarify. So this was my patient, as usual, the 43 years old lady having 150 by 95 millimeter mercury. There was nothing remarkable in her, excepting that when she came to us with many previous reports showing that she was having sustained hypokalemia. So at that point, we really had little to do. We thought that we are going to work on that lady. We thought that we'll send the aldosterone and other things in some country, and probably we'll arrange the renal vein sampling because we were doing cardiac catheterization at that time, and we thought that it will be an easier job for us to collect the suprarenal vein and the blood from suprarenal vein and make some heroic diagnosis. So they remain vacant. We could not do those things. The aldosterone, which is required for screening, the renin concentration, and the ratio of aldosterone and the renin is important. And finally, in some cases, the saline loading dose confirmed the diagnosis. So again, as I said, by assessing the sample from the left and right renal vein, that is required for localization of the tumor, because the anatomical localization is not good enough to predict where the lesion the patient really do have. So at that time, we had CT scan done for this patient in the April 27. At that time, we had 32 slice CT, which failed to show any lesion in the suprarenal gland. But fortunately, there was 64 slice CT at the then Apollo Hospital, and where they found a small nodule in the adrenal gland. At that point, we thought that we'll collect the blood and we'll send it to some agent in the neighboring country. But the patient, she was an affluent patient. She went abroad and had her adrenalectomy done. So the golden rule to be followed for patients with endocrine disease are you have to have the biochemical diagnosis first. And for the biochemical test, you need to prepare the patient. You have to collect the blood properly, And you have to know what the laboratory is doing, what is their standardization, what the unit they are using. Probably that are the all things that we need to do. We need to know what the patient we are going to send for screening. We have to know how to prepare them, and we have to also know the interpretation of the laboratory data. Primary aldosterone is quite common, pretty common, 10% of the all hypertensive patients. And if you consider 1.3 billion people population of hypertensive all around the world, it is a huge task. So we need to really screen the PA, the pulmonary aldosteronism, and there is very high risk of associated cardiovascular morbidity, 4-time increased risk of stroke, 6-time increase of non-fatal myocardial infarction, and 12 times more atrial fibrillation. And more importantly, the antagonists are the game changer. If you can pick it early, if you can treat it early, there is a huge benefit, I think. So this is no longer just a secondary hypertension. We really have to do aldosterone screening in all patients. Maybe if you are financially constrained, there are certain selective patients for whom you can be selective, but otherwise all patients with hypertension should be screened for Crohn's disease. So screening protocols, every time we need to know whether the patient has got hyperkalemia. We have to liberalize the salt. We have to stop some medication, and we can continue with verapamil and prazosin. But if you really need, you may have to stop the AC inhibitor and the calcium channel blocker. And as I said, you have to really be careful about the way you are collecting and preserving your sample. So also, you have to keep in your mind all these factors when you are analyzing the whole report. And look at just a significant some number, aldosterone-renin ratio of more than 20. And if you do a confirmatory saline loading test, it should be more than 10 nanogram. These are the drugs that really affects the test. This is one of the protocols that you may peep through the loading dose protocol. And there are other confirmatory tests, but probably the saline infusion test is the most preferable nowadays. And adrenal CT are done to localize that lesion, but all the time it is not the foolproof, because you can have incidental microadenoma over the age of 35. And in that case, as I said, you need to assess the adrenal venous sampling to know actually where the lesion is. So this is some of the protocols. And at the end, you can have an algorithm where you can really manage the patient. The main important thing is what we can see about primary pulmonary aldosterone is it is just the peak. And in 10% of the cases with real risk population do have screening for primary pulmonary aldosteronism. One report from this part of the world showing 17% prevalence in the young of primary aldosteronism in young hypertensive patient. This is one of the famous studies, including 150,000 patients, of which 5,000 had resistance hypertension, but only 2% went for test for hyperaldosteronism. So we really have to be very careful, very cautious, very agile in finding out hyperaldosteronism in many of our patients, probably in every patient. There are other causes of endocrine hypertension, relatively rare. If you have paroxysm attack, we know what is triad of paroxysm, that is anxiety, headache, and palpitation, then you go for pheochromocytoma diagnosis. You have plasma-free metanephrine and the urinary metanephrine and normetanephrine. For localization, you can do CT, and for functional imaging, you have other tests. I found it to be quite impressive that when it says that urinary metanephrine and urinary normetanephrine with the upper cutoff value twice had got sensitivity of 95%. Of course, you can have this MIBG test at BSMMU. Endocrine Cushing syndrome, we suspect when the patient has clinically Cushing syndrome, and we do cortisol at 8 a.m., for circadian rhythm at 11 p.m., single night test and the low dose and high dose test. And for localization, we do the anatomical CD and other things. Ladies.
2 minutes, please. Thank you, sir. Thank you so much, sir, for your brilliant speech. May I